This is Antonis Vasiliadis. I am an otolaryngologist, specializing in audiovestibular medicine. Today's topic is the implementation of a balance platform into your daily practice. Balance is the ability to maintain the body's mass center over its base of support, or we can say that is the ability to control our body's position against gravity.
Static balance is defined as when someone holds a stationary position with control. Think of the freeze or statue games. Dynamic balance is defined as when someone remains balanced during a movement. Think running or riding a bike. Let's make sure we're all on the same page and talk a little bit about how balance works. This is achieved by a complex mechanism, as you can see in this graph. This neural network includes sensory input from vision, proprioception, and vestibular system on one hand and motor output to eye and body muscles on the other.
The balance system is responsible for seeing clearly while moving, knowing which way up, what direction, and how fast is the head moving.
The brain is making real-time posture adjustments to catch you if you are losing your balance, walking on uneven surfaces, or performing demanding motion tasks. This is an overview of the postural control mechanism. At the beginning, the brain determines the body's position in space, and then the premotor field is planning, and the muscles execute the desired movement under the continuous supervision of the cerebellum. How common health issue is imbalance and dizziness? What is the economic impact? Why should someone invest in a balance platform? In 2016, 36.8 million adults reported a balance problem in the U.S. In 2015, more than 28% of the population over the age of 65 reported a fall in the past 12 months. The cost for the American healthcare system caused by falls was estimated at more than $49 billion in 2015. How can we evaluate balance disorders from a neurologic perspective? What diagnostic tools do we have in our hands? Do we need some kind of special equipment for this evaluation? In 80% of cases, a reliable diagnosis can be made from a detailed, well-organized history taking. This is mandatory, and no equipment, so far, can do the dirty job for us. The main purpose of these expensive toys is to confirm our thoughts and our clinical findings and enlighten some dark or hidden spots in our clinical examination. All these devices can additionally offer you detailed data recordings for monitoring the course of the recovery and the treatment efficacy. Advanced new technology evaluates functional parameters that, until today, could be tested at a bedside examination. We have already mentioned the three systems that contribute to balance. Let's talk about the available test for the peripheral vestibular part. Video head impulse test, calorics, vestibular evokemyogenic potentials, rotary chair, subjective visual vertical, ocular counter roll, and dynamic visual acuity are some of the tests for the labyrinths. As we know, we've got 3 semicircular canals for angular acceleration and 2 otolithic organs for linear acceleration and gravity detection. Oculo-motor exam provides us with information about the central parts of the vestibular system and their effective cooperation with other regions of the brain, such as the cerebellum and eye muscle nuclei. The oculomotor exam includes gaze test, smooth pursuit, saccades, and the evaluation of optokinetic nystagmus. These visual stabilization mechanisms are very important because they play a key role in the treatment process.
So far, we have tested the semicircular canals, the otoliths organs, the vestibular nerves and nuclei, the descending and ascending pathways in the brainstem, as well as some parts of the cerebellum. On the slide is obvious the complexity of the involving neural network. And that's all. Do we need something else to know? Have we completed the examination? And are we ready to discharge our patient?
What about his major complaints? Walking difficulties, unsteadiness, maybe some falls, inability in everyday activities, and many others. Does anyone visit you and tell you just that his labyrinths are damaged? Our main goal must be the individual's balance as an entirety and observe the problem from different perspectives and angles. This strategy opens the evaluation for physiotherapists and occupational therapists. who already work in this field. Why is this holistic approach important? Daily life requires us to accurately organize sensory information provided by our three sensory systems. So, at the end of the day, we must answer some questions about the balance mechanism. What is the impact of a vestibular impairment on balance? Does the presence of a central deficit affect posture and walking ability? Are the vision and the somatosensory system able to maintain a satisfactory functional status? How does the subject react in darkness, or with lack of visual depth, or even when large objects are moving nearby? What is the impact on balance when proprioception becomes unreliable on uneven surfaces like stones, sand, and grass? There are various clinical tools that we can use to evaluate functional balance and gait. Modified clinical test of sensory integration and balance, modified Cobalt test, Romberg test, unilateral stance, balance error scoring system, limits of stability, functional gait assessment, dynamic gait index, gait speed, Tonetti gait index are some commonly used tests. For most of them, all you need is a stopwatch, a datasheet, a tape, and maybe a foam pad. All this provided information is useful to establish a general idea of the problem. What is the response pattern of the subject in various conditions? How can all possible underlying pathologies get together and form the final clinical picture? We can divide the tests into subjective ones, as we mentioned before, and objective ones that require the use of special equipment to perform the measurements. The benefits of an objective functional assessment are objective data rather than a pass-refer approach and an improved baseline setting for monitoring the treatment's efficacy. Comparison against normative data. Applied technological evolution to the equipment allows clinicians to better identify functional deficits. Vestibular training can also be provided using physiosensing. On the right side of the slide, you can see every computerized test that you can perform with the platform.
Based on the motor control mechanism we discussed earlier, we can separate the tests depending on whether they examine the sensory input or the motor output. You can also tell that tests on the left column evaluate static balance, and those on the right, dynamic balance.
The modified clinical test of sensory integration and balance is one of my favorite tests. It is very easy to perform. It takes about 5 minutes. mCTSIB assesses how different environments can change the patient's ability to maintain balance. Does a change on the ground cause significant difficulties? Does a change in vision complicate the situation? Research has shown that neither the position of the feet nor the footwear influence the scores. I prefer to perform it with feet together at a distance of 2 centimeters in between, without shoes. It is relevant for many conditions, and there are plenty of publications for every single one. By analyzing the charts and the hard numbers of our measurements, we can answer questions about the functional status, and then we can personalize our treatment. Additionally, the recorded data helps us monitor patients' improvement. This is how it looked the initial screen. Every condition needs 3 trials. This test records how the patient is using sensory inputs when one or more sensory systems are compromised. Each condition weights sensory input differently, allowing the therapist to gain insight into which system may be impaired or overworking. On a firm surface, the somatosensory system is the most involved in balance, followed by the vestibular and visual systems, respectively, 70%, 20%, 10%. On a compliant surface, this order shifts, making the vestibular system more active, followed by the visual and somatosensory system, respectively, 60%, 30%, 10%. In condition 1, all sensory systems are available for maintaining balance. In condition 2, vision has been removed, and the subject must rely on the remaining 2 systems. In condition 3, proprioception has been compromised, but vision and vestibular mechanisms still work. In condition 4, both vision and proprioception have been compromised, leaving the inner ear alone to do the job. Before moving on to interpretation, it's good to know that several studies have shown that mCTSIB correlates well with sensory organization test, which requires much more expensive equipment. Here you see the result charts. We're looking for mean cop sway velocity to be within Nemo limits, with a green indication, and the cop's alignment to be centralized, which means good postural control. Regarding the recordings of each condition, it is requested to maintain consistency and, as much as possible, the small ellipse area. Another request is adaptability between trails. The subject starts with a big sway, but the next trails are better. This means that there is an underlying good motor control network. On the other side, if the ellipse area getting bigger, this is an indication of fatigability, and maybe to consider for an endurance training program also. Let's move the results pattern. Failure to condition 1 indicates difficulties incorporating somatosensory information, as it is the main contributor to this task. Consider peripheral neuropathy, lower body weakness, and other musculoskeletal pathologies. Failure to maintain balance in condition 2 only indicates visual dependency. Why is this happening? If a subject is very stable in condition 1, all mechanisms are in good condition, but we don't know the exact proportion of each one. When the subject closes his eyes in the second task and he sways a lot, it is clear that he cannot use somatosensory cues effectively because he is used to relying on vision. This situation is very common in chronic conditions such as resisted postural perceptual dizziness, and we must follow a different therapeutic approach. We take baby steps during our rehab, as the patient fears a lot of motion. This is why it is important to previously perform HADS and dizziness handicap inventory, where emotional components can be identified, giving us an idea of what's going on. Inability to maintain balance in conditions 3 and 4 indicates that the visual or vestibular system is not being used satisfactorily. It is recommended that, if you are not a vestibular specialist and the inner ear hasn't been tested, you refer for further investigation in these situations. In general, mCTSIB doesn't localize the lesion, but gives us information if there is a need for a referral, and how to proceed with our rehab plan.
Limits of stability are a concept defined as the points at which the center of gravity approaches the limits of the base of support. In other words, lows represents the maximum distance that an individual can displace his center of pressure without losing balance. The typical range is 8 degrees in the front direction, 4.5 in the back, and 8 degrees in the side-to-side direction. This stable swaying area is often referred to as the cone of stability. Lows is a commonly used protocol for evaluating stability and voluntary motor control in dynamic states. It provides valuable biomechanic information by tracking the center of mass's velocity and position. It can be used as a screening test for fall risk, particularly in elderly populations where cognitive and attention deficits are present. Keep in mind that research shows that fall risk increases by 14 times in cognition deficits. We can also extract some psychological outcomes regarding how fast and far the patient is willing to move. If the reaction time is constantly slow but the other indexes are relatively good, this indicates an increased fear and anxiety component. Remember how often you deal with patients who avoid every movement, although the findings are normal. Think how easier it could be for them to realize it, getting a written report with graphs and normative data in their hands. If you gain the confidence of a person suffering from PPPD, this is the first big step in treatment.
This is the initial screen. The subject is requested to align his cop with the center red point, and when a peripheral point becomes orange, he must move his body to the point. He must avoid moving his hips and shoulders. Instead, he must move his body and block. This is a very demanding task. It is better to train the patient a little first and then perform the test. The test hasn't a diagnostic value for the underlying pathology, but rather assesses the motor strategies, so it is not necessary to perform it during the first visit. What are the possible causes of lows impairments? Impaired cognitive processing, most often due to aging. Neuromuscular impairments, conditions such as bradykinesia, ataxia, tremor, etc. Musculoskeletal impairments. Think of weakness, limited range of motion, pain, and lower limb pathology. Emotional overlay such as fear or anxiety. Imbalance due to vestibular causes. When the test is done, you get these charts. The reaction time is affected by neurological diseases, fear, anxiety, and cognitive deficits. The endpoint excursion, which represents the first part of the movement, could be low in Parkinson's disease. Ataxias and tremor affect directional control as well as cognitive deficits. A low maximum excursion can be found in restricted ankle strategy, muscle weakness, and general low weight transfer skills. The movement velocity can be altered due to age and other motor pathway pathologies. In general, from a clinical perspective, individuals with better lows can perform complex mobility tasks without support, and they are more capable of tolerating environmental challenges. Based on the results, healthcare providers can design specific exercises and training programs to expand these limits and improve direction control and reaction time. The PhysioSensing software offers a variety of games and exercises to train specific weaknesses in a constant way, and this increases the efficacy of the motor learning process.
Rhythmic weight shift. This protocol evaluates the transfer capacity of the center of pressure. What is the patient's ability to rhythmically move in the anterior, posterior, and lateral directions? The subject will be asked to voluntarily move at 3 different velocities: slow, moderate, and fast. The sway velocity, measured in degrees per second, is quantified and compared to normal individual scores. This test is appropriate for central nervous system pathologies, such as stroke and brain injury. Degenerative diseases. Think of Parkinson's disease, multiple sclerosis, peripheral neuropathic disorders like diabetes and polyneuropathy. It is a good alternative method for motor evaluation if the subject cannot perform the Lowe's test. It gives us useful information about velocity and directional control. It has been found that reduced speed of movement increases the fall risk. If there is poor directional control, the impact on ADLs is huge. Avoiding obstacles, moving in the crude, crossing the street, and many others cannot be safely performed. These difficulties require a lot of brain effort to anticipate, leading to decreased dual tasking ability. People with multiple pathologies are crucially tested for directional control. This is why some of them with vestibular loss have minor complaints in everyday activities, and others have an unexpectedly increased impact on their lives.
This are the results presentation. On the left, it is the area where the movement is limited at the both axes. On the right, we see the direction control in green and in red, depending on the patient's performance. The Romberg test is primarily an old neurological assessment to evaluate a person's balance and proprioception. It has been used for over a century now. The test assesses the function of the dorsal column of the spinal cord. It is also sensitive to measuring the degree of disequilibrium caused by central and peripheral dizziness. Romberg's test is positive in conditions such as vitamin B12 deficiency, neurosyphilis, peripheral neuropathies, Friedreich's ataxia, bilateral vestibulopathy, and in some cases, uncompensated unilateral dysfunction. From a clinical perspective, it is very similar to mCTSIB, except that the feet are placed together. As you can see, it is very easy for the patient to understand the differences among the 4 conditions. On the right part of the slide, there is every one measured parameter. This is the initial screen on the software. This is a protocol for fall risk screening. It is recommended to perform with elders who have more serious kinetic difficulties. It requires 4 conditions and compares comfortable and narrow stance results without the use of a foam pad. The patient must stay still with hands on his hips for 45 seconds, looking straight ahead. The recording of the center of pressure trajectory forms the statokinesigram. The bigger the green ellipse area on the right, the more unstable the subject is. This test could be combined with a time up and go and functional reach test. For those, it does not require special equipment, and they are easy to perform in comparison with the limits of stability test. It can be done during the first session. Considering its simplicity. In this way, we compose a fast, full picture of the postural and motor performance of older people. In the time domain, the graph is called a stabilogram, and it shows the mediolateral displacement. The software calculates the mean velocity and the sway velocity index. Here you see the differences in the amount of displacement. Research from the Ohio and Finland groups gave us normative data for ages over 50. As you can see, the results in this graph are given in a very clear way, and the patient can realize his performance under tested conditions. A red bar indicates a high fall risk. This is my favorite initial test for the elderly with comorbidities in order to identify a potential faller. If the test is positive, you first have to reconsider polypharmacy, which increases fall risk, and take care of changes in your client's environment regarding night lights, bathroom reformation, handles, etc. Second, you have to reduce fall risk through appropriate exercises and then deal with other complaints such as dizziness or lightheadedness. In these cases, special vestibular training is better to be supplementary at the starting point of the therapy. On the lower right corner, you see the vicious cycle, which should be broken for a successful treatment. Unilateral stance or single leg stance is important to be tested. Remember that 80% of the gait cycle involves single leg support. Unilateral stance protocols are used mainly to monitor neurological and musculoskeletal conditions. It is very often used for athletes with lower limb issues for documentation and data collection. We can, among other things, identify asymmetries originating from injuries, recent or old ones. We could even use it with athletes without any problems, just for monitoring their balance skills in one leg, such as basketball players, gymnastics athletes, skiers, and others. For these demanding clients, there is also the best protocol, which is based on single leg stance. Regarding vestibular patients, I would use it if I wanted to identify any asymmetry that could affect my treatment results and slow down my treatment's progress. This is the initial screen of the test. The patient is instructed to place his foot to the marker, and then we go through 3 of 10 seconds trials with eyes open and closed for both legs. The software evaluates the sway velocity difference between the left and right sides with the eyes opened and closed. The bar points to the side with better performance. These values are presented along with the normative data for the patient's age, where you can see the cutoff value. In addition, the center of the pressure trace for each condition can be observed in the second picture. Results outside the normative values or a fall in one leg are sensitive indicators of motor impairment, but they do not provide information about their nature. For those of you who evaluate kids in your clinic, single leg stance is very important. Single leg balance is a building block for more advanced skills that your children will develop as they get older. These skills include kicking a ball, hopping, and skipping. It is also used during functional activities, such as putting on pants or shoes and stepping in or out of the shower. At 16 months old, your child should be able to hold something and lift one foot up. At 24 months old, your child will be able to lift one foot to kick a ball. By the 3rd year, children can balance on one leg for 3 seconds. By 42 months, the time rises to 5 seconds, and by 5 years, the cutoff value is 10 seconds. A study in 2022 shows that single leg stance is a fast and efficient way of predicting vestibular loss in school-age children. You can build your own unilateral test protocol in the body sway module and record your little client's data. Body sway protocol gives you the opportunity to build your own protocol by changing all these parameters. The Total Balance Pro combines 3 separate protocols: the modified clinical test of sensory interaction on balance, the limits of stability, lows, and the sit-to-stand test. It collects all required data and presents the results through a hexagonal diagram which contains proprioception, vestibular and visual input, postural stability, lower limb strength, reflexes, and reaction time motor control. This new protocol is provided for the pressure plate only. If you want, you can start the evaluation with this protocol. The only limitation is for people with advanced balance problems who cannot complete the Lowe's test. For these situations, I suggest the fall risk, combined with the time up and go and the functional reach test, as I have previously mentioned.
In the upper part, you can see the icons of the 3 protocols used. At the lower part is the final hexagonal graph, where the results are presented. This results visualization makes the interpretation very easy and indicates the treatment's needs. If a patient has a big sway when their eyes are closed on stable ground, this means that proprioception is affected, so you have to work on this. Abnormal 3 and 4 condition means possible visual and vestibular impairment, so the score appears low on the graph. If postural stability is not good, it means that you are dealing with a potential fall. Lower limb strength is crucial for clients' independence and activities of daily living. So, it is better first to apply an endurance training program if the score here is low. Motor control and reaction time show the kinetic capacity. How does all the sensory input transform into an effective movement? If the score is decreased, work with reflexes, coordination, and other motor tasks. It is easy to understand that a different rehabilitation approach must be followed if we are dealing with a sensory instead of a motor deficit. In general, Total Balance Pro protocol is useful for vestibular impairments. It combines different tests and gives simple, clear information about what's going on in the functional field. What next? In the second part of this presentation, we will discuss about rehabilitation capabilities of the platform. Thank you all for the attendance.